All right, and with that, good morning, everyone. The panel is going to introduce themselves this morning, so you won't have to hear me go through all the bios, but welcome everyone. And we're going to have plenty of time for Q&A throughout the session. It's correct that you would like folks to go ahead and type in their questions as they think of them, and they will be addressed throughout. Is that correct? Okay, perfect. Well, welcome everyone. And like I say, please use the Q&A tool to type in your questions for our panel. And we're very excited to get started. So I'm going to turn it over to Troy Kastrup.
Thanks, Joe. Hi, everybody. I'm Troy Kastrup. I'm the president of Wapiti Medical Group. We help staff quite a few critical access hospitals in some other areas. I'm excited to be here because I grew up just outside of Sioux City, so I understand the dynamics of the Iowa Hospital Association. I've seen how groups work well together in Sioux City when there was tragedy back in the 80s and through that. So that's exciting to be here and visit with everyone and provide some information. And having been to the IHA show, this state has the most dynamic group of administrators that show up with 1,200 every year that show up to the national convention or the state convention. So this is exciting. So I'm Troy. With my partner, Jen, we will be facilitating some of those questions, and we will be looking at the Q&A box down below. So if you have those questions, Joe said, throw those in there. Go ahead, Jen.
All right, good morning. Jen Lloyd. I currently serve in the Vice President of Operations role here at Wapiti Medical Staffing. Prior to that, I worked in critical access facilities for 20 years. So I very much understand the hospital situations and have lived it in various roles. So I'm excited to be here at Wapiti serving in this capacity in order to understand how to best serve all the hospitals that we are fortunate enough to partner with. So with that, I will turn it over to Dave.
Good morning. I'm Dave Crone. I'm an attorney based with the Woods Fuller Law Firm in Sioux Falls. I'm one of about 40 lawyers here. We also have offices in Sheldon and Sioux Center, Iowa. I've been practicing for about 30 years. When I first started, we did not have an employment law or a health law practice group. Times have changed. And it's been an exciting year in a number of ways, challenging for a lawyer. And I suspect with the change of administrations, it'll be an exciting 2021 as well.
With Dave incomplete, go ahead, Mike.
Great, thanks, Troy. I'm Mike Schaefer. I'm the CEO of Spooner Health. Spooner Health in Spooner, Wisconsin is a critical access hospital. Also operates a home health agency and partners with 4 other area hospitals for a regional hospice that covers 2 states and about 10 counties. So some real uniqueness in COVID times with that operation as well. My whole career has been rural hospitals. I spent, prior to my 30 years I've been here at Spooner, I spent 5 years as an administrator in both central Minnesota and northwest Wisconsin. So I have a real passion for rural healthcare. As everyone on this webinar knows, this has been a year like any other in my 35-year career, and looking forward to have a chance to discuss some of the things we've done at Spooner during this time. So thanks.
Ralph, tell us about yourself.
All right, my name is Ralph Llewellyn, and I'm a partner with Eide Bailey. I'm based out of Fargo, North Dakota. My background is I started out as a hospital CFO, spent about 5 years as a hospital CFO in rural North Dakota. About that time, right before critical access hospitals actually came into play, I came to Eide Bailey back in 1997, just as the Balanced Budget Act of 97 was rolling out, which gave us critical access hospital programs. So I've been keeping most of my time busy over the years in that space. I am the director of critical access hospital services. While I work for an accounting firm, I am not an auditor. All my stuff is around the area of cost reports, charge master, reimbursement, operations, staffing, basically anything that touches licensure and dollars and cents coming in and out of the facility. So glad to be here with you guys today.
Okay, thanks, Ralph and Dave and Mike. So I do have one question here pinged in here, but yeah, this is a group that can give us expertise from what they've studied and what they're experiencing in the field. And the first one that came up, and I'm gonna start with Dave, and Mike, you might be able to follow up with that question. timing is perfect here with the vaccinations coming out. Can we require employees to be tested to be at work or return to work? Is there a risk with requiring masks, wearing them when the state does not have a mandate? So let's start with the vaccination question.
You got a couple different issues. You've got a testing issue. And so EEOC has made it clear throughout last year that employers can require a COVID test to come to work, and also are permitted to test employees periodically to make sure that they are safe to be at work. The reason for that is, generally the ADA doesn't permit that kind of approach, but the ADA believes that in the absence of that, an employee could pose a direct threat to the workplace. And so the EEOC has made a determination that not only can an employer test for COVID, they can, as we all know, they can ask questions, they can take temperatures, they can ask where you've been on vacation. So they've been very flexible in trying to maintain that safe workplace. The one thing that an employer can't require yet is an antibody test. And as you all know, an antibody test is of questionable accuracy right now, but it indicates whether you have had COVID in the past. That's the one thing an employer cannot require. With respect to masks, yeah, again, the general rule to avoid liability is an OSHA rule. The general OSHA rule is that an employer has to maintain a safe workplace. And OSHA has generally said that if you follow the CDC guidelines, you've satisfied the safe workplace guidance. And the CDC obviously recommends a mask. So yep, an employer can require a mask. I've had situations where I've had clients who have had employees that have certain respiratory conditions that they can't wear a mask. And like all things, you have to accommodate individuals with certain disabilities. So if you have an employee whose doctor says, hey, Joe can't wear a mask, you have to come up with other alternatives. Can you do a shield? Can you do partitions? Can the employee work remotely? So generally, yeah, the employers can require masks and probably should require masks.
Perfect. Mike, in that aspect, you're in a facility. Are you getting a good reception with some of those mandates? And what is your mandate?
Yeah, we've mandated masks since the beginning. We are mandating that employees self-check temperature every day, log in coming to work. And we've had very good response. We are starting to get pushback now that all of our frontline staff has been vaccinated through and had both doses of vaccination. We're starting to get pushback. Why are we still having to report temperatures? We just recently had to put an employee on quarantine who has been fully vaccinated because of a family member getting COVID, and CDC guidelines still recommend that even if you're vaccinated, you still need to quarantine because you theoretically could be a carrier. I'm not aware of any vaccinated virus where you truly are a carrier. So we're starting to have to grapple with some of those things, and I'm sure we'll be contacting our legal counsel in the very near future about some of those as well. As things change and as we vaccinate, it's opening up a whole new set of questions from our employees.
Mike, I know that the vaccinations are a pretty important topic that's happening right now in everyone's world. I know from your perspective, I'd like to hear a little about how you were able to do some coordination with the facility, region, community in order to make that happen.
We've taken a very proactive approach. We're in a county of about 14,000 people here, and we have another rural hospital that sits 7 miles south of us. And for months now, we have been meeting with our public health, with the two hospitals and the 2 other clinics that are unaffiliated with either hospital, meeting to talk about, what we're doing. So we're consistent in our policies of masking. We're consistent in a lot of that, but to prepare moving forward. And we were one of 24 hospitals out of 130, I believe, that got vaccine with the first allotment. And we're fortunate to be able to vaccinate all of our staff that qualified, that wanted it, and more, because we had extra. partially because the CDC allowed us to take 6 doses out of the vials of Pfizer rather than 5. What we did then is we partnered with our local public health, as we've been talking, and the other hospital in conversations, and we kept ordering vaccine, and we were able to vaccinate all of the 1A healthcare workers in our county that wished or desired to be vaccinated. So we've seen unprecedented coordination when it comes to the whole response within our county. The other thing I also witnessed that I thought was great was health systems that seldom talk. Talking with each other. We have Essentia Clinic in our town. Essentia's out of Duluth. I was invited to regular calls with the Essentia leadership, the St. Luke's Hospital leadership in Duluth. Marshfield Clinic, which has a clinic and hospital 25 miles south of us, did the same thing. And just unprecedented cooperation. We saw Marshfield and Mayo both on those calls. So it was really great to see how people pulled together, competing systems working together for the good of their communities.
Okay. Dave or Ralph, if you have follow-up, just pipe in. Otherwise, I'm going to go to the next question here. It's almost where we started with employees. And I'm going to start with Ralph on this, but I think Mike and Dave, you may have something to say too. You have volunteers in your facility. What sort of regulations are they subject to? And I think, Ralph, you may have something to say to this. What considerations when using volunteers?
Well, I think the biggest piece you got to look at is, how do you protect them as well as the others coming in? I mean, that's going to be the biggest part, with employees. And obviously, we got Dave on the call with, from a legal perspective, you got things you can deal with there. These aren't employees. So, I think trying to understand, how do you know where they've been? How do you protect them? Sometimes they're not as privy to the methodologies of protection and the risks and things like that, because they don't operate in a regular healthcare setting. That's been the biggest thing I've seen as I've been talking to providers on how they're dealing with their volunteers. A lot of them have tried to almost disconnect that at this point in time, just because of the concern of being able to keep them educated enough to protect themselves and others.
From a legal perspective, you're right. A lot of times they're not employees. They're not independent contractors. They kind of fall in a little bit of a gray area. But I think as an employer, again, going back to what I said earlier, you have an obligation to provide a safe workplace. And so I do think you have the right to require volunteers to adhere to those kinds of policies that you do everyone else: temperature, mask. And I do think that, if they want to volunteer, I think you would be able to require a vaccination. And obviously, if they don't want to do that, they don't have to be a volunteer. So I think the way to look at it is, how best do you protect the workplace, and whether it's a volunteer or an employee or an independent contractor, I think you have the right to mandate certain safety requirements in the facilities, and that extends to all the things we're talking about.
I would just comment, we have not used volunteers since March. When we look at our volunteer pool, they're almost all over age 65. So they're the most vulnerable. And we made that decision back in March. So our greeters, our transports, our gift shop, we just haven't had volunteers in the facility, and it's killing us, to be honest. They are such an important part of our community, eyes and ears to the community too, but they respect what we've done. If we are allocated vaccine tomorrow, they are the top of our list next week of people we're vaccinating. And we've had almost 100% of our volunteers want to be vaccinated. I would say half of our volunteers are former employees or former healthcare workers as well. So I think they understand the importance behind it. So, it's been tough not to have volunteers in the facility because they play such an important role, but our goal has been to keep people out of the facility unless they absolutely need to be here.
Mike, I'm sure in your incident command or your future planning for what's next after COVID, as we all adjust to what the new normal is, have there been conversations about when, if, and how to bring the volunteers back into the facility?
First off, we don't refer to it as the new normal around here. We call it the normal for now. We're hoping something changes. We have started having those conversations, but we're really starting prior to that with employees and how do we deal, how are we going to deal with mask mandates in the future? We're really closely following CDC guidelines on what we do. And I think we all know the CDC is behind when it comes to certain things. We still have to quarantine an employee who had COVID, who has an exposure, if it was 91 days ago, because CDC is saying you're good for 90 days. Research is showing that you still have immunity at least 9 months later. So we're hoping some of those things change. So we try not to get out in front of the CDC in how we look at those. As far as volunteers go, we just started that discussion again. There are things we think volunteers can do here that do allow social distancing even after they have the vaccination. Things like our greeters, although we now have screening tables set up and screening everyone coming in, so it kind of takes away some of their duties. So our incident command has just started discussing that. We still meet weekly. We were meeting 4 times a week at one point, but we haven't come up with any decisions regarding volunteers yet.
So I have one more question to tag on to that. I apologize, Troy. As far as employees go, especially in a rural facility, employees wear many hats. We do what we have to do to pitch in and make sure everything's taken care of. So how has it looked for you? And I think Dave, you might have some thoughts on that as well. As far as employees performing work outside of what their quote unquote job description is, or there's always the other duties as assigned. However, how does that look? How has that looked, and how can that look as you move forward with whatever the normal for today is?
Well, I'll jump in first. And I think it depends on whether the employee in question is subject to a written employment contract, like some management might be, or whether they're simply an at-will employee. If they're an at-will employee, the employer generally can dictate the job descriptions from day to day. And so if things change and you have an at-will employee, from a legal perspective, I think you're free to make that change. I think where some employers have gotten tripped up through COVID is that they've tried to do that with employees who are subject to written employment contracts, which often include a very specific job description. So you have to kind of figure out what kind of employee you're looking at. One common issue that lawyers are going to be dealing with for the next year is, just as an example, not necessarily job description, but pay cuts. And in the private sector, a lot of employers required temporary pay cuts to get through the economic mess. And of course, a lot of the employers didn't think about employment contracts. You've got some employees out there that say, Joe shall be paid X dollars every month. And so you're going to have a slew of litigation coming up because employers, in good faith, trying to survive, required a pay cut. In 21, Joe may come back and say, hey, you need to make up that difference. So that's going to be something that's lurking on the horizon, at least in the legal world.
The other thing that we ran into that I think we handled in the appropriate way is we have a union here, and it's a very small percentage of our non-professional staff, support staff. When we made the decision that we were shutting down our surgery, we were shutting down our rehab department, certain things on an outpatient basis we were not doing, we sat down with our union leadership right away. And we got word out to our employees. I went to the board of directors, and we are sitting in a very fortunate financial position, to be very honest. We built a new hospital in 2016, but we've been sitting good. And one board member questions the money we have in the bank sometimes. And I always say it's nice to have a rainy day fund. Well, we figured out this was our rainy day because the board committed that early on we were not going to lay anybody off. So we could bring that forth. In that message and talking with the union and the leadership, their support was, hey, you're keeping us employed wherever you need us. We're not going to give you any problems. We're going to reassign. With surgery not being open, as a small hospital, our nurses are typically trained to 2 different areas. So our surgical nurses, we put additional people in the ED, our emergency department. We could flex to the floor. And quite honestly, for a while, we had a lot of people, not a lot, but some people sitting around not doing a whole lot. I can think our rehab department caught up on all their continuing education, for the next year. But I think our communications that we had with staff to say, at least early on, we're not looking at laying off any staff, and it got them to buy into we'll do whatever it takes. We had people, the touch spot cleaning we were doing, we had physical therapists occasionally going out and doing stuff like that. We had a great response from our staff. And I think it was due to the communication. We then qualified for a PPP loan, being a small facility, and that helped us to keep the staff on as we started slowly reopening different departments as we learned more about the virus. And think of how your community reacts. At the point we were doing this, we maybe had 2 cases in our county. We were very late, I don't want to say late to the party, I almost said, but for seeing cases, we were down the road a lot from the eastern part of the state. So we're making decisions based on the stuff we're hearing, yet we don't have COVID in our community. So it was real interesting communicating with the staff on that.
You talked about PPP money, Mike. So I'm going to, Ralph, there's some things that have come down with the CARES Act, PPP money. What are some things, potential pitfalls, stimulus funds, advance payments? What are some cautions out there that everyone should be aware of?
Well, I think, first and foremost, you need to start with figuring out a plan, with the end in mind as to what's going to happen as far as which of these funds have to go back, which of these are temporary as far as advance payments. And after that, it's really starting to try to figure out the rules, which in all honesty, in all fairness to the providers, has been a real challenge because we never know when they're finally going to give us the rules. As an example, the Provider Relief Fund rules, they give us money in March and tell us how we can spend it, and they're very, very vague. And then about every other day, they give us a new update. Sometimes it's clarification, sometimes it's exact contradictions. Here we are in January of 2021. We just got on Friday of last week the updates on reporting, but yet it isn't giving us everything we need. And we're still not sure what we're going to need to document everything that we have to spend by June 30th. So when you think about it, HHS has had more months to tell you what you can use it for than you're actually going to get to plan and spend it and do everything right. So there's a lot of pieces that go into that area. With that, I think as you look at the uses of the funds, I think you really need to step back and be creative in your thought processes of, how will you use these to best position yourself for taking care of the risks today, but also putting things in place that are going to help you long term, so that this is truly a good use of funds, a good investment of funds and things like that. But understand that there's an audit process. And there's enough dollars and cents in here that we know that there are going to be audits out there. So you really need to start working on your documentation and build that as you go. Don't think, well, gee, we'll document it later, because you lose so many facts and pieces that you need down the road. And the audits on the back end are really ugly. The other thing to be concerned about is anybody who tells you that they know all the answers and can guarantee that this is going to be covered, because there are a lot of them out there. There's a couple of groups and associations out there that'll say, absolutely, that's covered. Absolutely, this is covered. And I'll tell you, you're not going to get that from most of the people I know in the industry, because they're going to say, this is what we understand today. Here is an example of what's been written in the rules. Here are some interpretations, but because of all the changes, all of our plans today could be totally moot tomorrow. So you really got to be planning that all out. And I think if I was in Mike's shoes, I'd be communicating to the board what we're doing, with these dollars and cents, and letting them know that the challenge is all of these moving rules and things, but we have to put a plan in place. But there's a risk with that plan, because tomorrow Mike might find out that he spent money on something that seemed appropriate today, but tomorrow they say you can't use it. And now the board's up a little upside down as far as where you're at with cash and financials. You just need to do a lot of communication so everybody is on board, because you're being transparent.
Mike, who do you use for a resource with all those moving parts?
We use our auditing firm as well as our attorney firm in Milwaukee. Okay. They do a very good job of keeping us updated. But I think Ralph's exactly right. We, from the time we started getting CARES Act money or the PPE, we were advised you might as well get advance payment, your Medicare advance payments. What's it going to hurt? So we tried to stockpile cash in that way, but then to use it for what it's appropriate. I have a great CFO, and she stays on top of this, knows a lot more about it than I do. But I know the recent guidance that we are going to be able to use our revenue losses compared to budget versus versus actual of the year before, because we've been on a good growth plane, will help us out as well. But I know, like Ralph said, that was what they came out with last week or the week before. Who knows what they're going to say next week? So we have presented a report to our board every month that shows all the money we've received outside of normal, whether it's CARES Act, whether it's PPE. We've presented what we've used it on, how we are using some of the CARES Act money kind of to backfill our revenue in our income statement. And there's always a huge disclaimer to the board that says this is based on the information that we are receiving, from the people we trust, our attorneys, our auditors, but it's all subject to change. And each month we typically get to tell them of at least one thing that has changed. So hospital finance is difficult for boards to understand in the first place. And now you throw this at a community board with all these, what ifs, and this could change, makes their job a lot more difficult too.
So Ralph, a couple questions maybe for Mike as well, as far as with payers. How do you see, and what changes do you see coming on the horizon with payers, negotiation with payers, payer reimbursement? Do you foresee any changes or any upcoming pitfalls with that?
Well, I think there's a couple of things that we really got to watch. I think we got to watch, what's going on in the area of anything that has to do with technology type services that we're doing. Think, telehealth, virtual visits, remote monitoring, all those kinds of components. If I think we're going to see some of our payers are going to be on board with it because they've seen how it works. There'll probably be some caveats around when and how it can be used, but I think that those are going to be the big areas to be watching. I think the more progressive insurance entities are going to be looking at that. That's something they need to lay out there. But I think you're also going to want to watch what the payment is on that, because getting the coverage of it, getting that into the contracts is one part of it, but making sure that the adequacy of the payment is there. And for my rural providers, I'm really concerned about that if you're looking at telehealth, because telehealth itself, if you're not careful, ends up being kind of the other pariah of healthcare. We know mental health has had a hard time getting for decades, getting the payment it needed. I'm concerned about telehealth because Medicare's, the precedents that they've put in the lack of payment there. You think about being a originating site and you're getting $26 a visit for that, doesn't even come close to your cost. If they start basing their payments there, I think that's where your pushback's going to have to come. But you're going to have a reason for your pushback. And I think it's the pushback you have there, as well as when you're asking them to add coverage, is you really need to be telling them why it's a benefit to them and the patient. Because I think too often what they hear is why it's a benefit just to you. And we need to be selling this of how does it in the long run control total cost. It is better to have telehealth because people are seeing things instead of showing up in the ER, crashing, being in an air ambulance, all those things. I see people having to put together a better story as they go in, rather than them being viewed as just saying, we want more money. Because everybody wants more money, obviously, in this time. And that's going to be a tough argument on its own.
What are some best practices, from an employment perspective, Dave, from a financial perspective, Ralph, and from a facility perspective, Mike, around reimbursement for telehealth and telehealth implementation or continuation?
I'll just take a swing in terms of you have employees working remotely. Employers aren't generally very good about communicating what the expectations are in terms of expenses. I'll give you an example. At our law firm, we went remote for a while, and you've got questions about, are you going to reimburse me for my internet access? Do I get reimbursed for the paper I use in the printer? All those kinds of little things. And so I think an employer is generally free to reimburse as it wants. I just think that in advance of any remote work, the arrangement needs to be communicated. Is the employer going to reimburse for certain kinds of expenses, or are they not? I think, at least from an employment perspective, I think they're free to contract any way they want. It's all about the expectations up front, in my experience.
You know, the one thing I would add to that, because, you know, there's the legal side, and then there is the ability to attract talent.
Right.
And, you know, I've had a lot of providers saying, well, what's the legal piece? And I'll say, well, you got to talk to your legal people, but I think you need to think bigger than just the legal side, because you need to understand that when we went into this, the competition for employees was probably fairly tough anyway for some of us. But now that everybody has basically went into a work from home methodology, people are realizing, both the employees as well as entities, that I can employ anybody, any place in the country. And so now you have a new competitor for your staff. And so I think you really need to look at, you know, yeah, maybe I don't think I want to pay for this, but if the competition in the market is saying, hey, work remote for us, we'll cover all these things on top of your compensation, that's a whole different conversation than having the you know, discussion with your attorney about what am I required to do. And I totally agree with Dave about, you know, you want to get that expectation up front, because we've got 3,000 employees that are mostly remote right now. It's rare. This is like day 15, I think, in a year that I've been in my office. You know, it's a whole different mechanism in the competition. So I think you got to think about that. The direct out-of-pockets, the direct expenses, those I think are the easy ones to say, yeah, those are probably just replacements of what I would have expended. I think David's comment about like the internet, you know, how do you handle that? You know, because that's something that they probably already had before. Everybody has that. But so I think you got to look at the competitive landscape.
I would say from a provider standpoint, we don't operate our own clinic, but I hear a lot from our physicians. One of the big concerns we have here with telehealth and visits is broadband. I live 4 miles from town. And when I'm home on quarantine, I can't have a Zoom meeting if I have a kid excuse me, I should rephrase that. I can't allow them to play video games if I'm having a Zoom meeting because our broadband is so bad. And you see the lagging time occasionally. So when I hear from our physicians, they deal with mostly an elderly population that struggles with the technology of doing a visit. They feel that sometimes, even though it's their MAs who are setting up the visits, they seem to take almost longer trying to communicate through telehealth. Some love it. Some aren't big fans of it. And what we're hearing is some insurance companies, Medicare is talking about paying less for a visit, and the doctor's spending more time sometimes on these telehealths. As a patient, my daughter had a first visit with a new neurologist on telehealth, and I was amazed at what they accomplished, how they did the exam. They did different things as a patient's dad. But there definitely was something missing. A month later, we were down in their office, and to me, it was a much better experience. So I think they're still figuring out how to make telehealth in the cases where it can work as well as an in-house visit. But I do agree with Ralph. There's lots of circumstances where a telehealth visit will save a visit to an ER or an urgent care center or something, and it's the right way to use telehealth.
You know, there's one other piece on telehealth that I've been having the conversation with providers is, you know, I think in the rural setting, at times we look at this as a risk because, you know, others could be trying to push these services into our market and we could lose some share. I think there's an opposite twist to that, though. In North Dakota, as well as anybody that's upper Midwest, to hear, you know, we have snowbirds. And traditionally what happens is when the snowbird heads for Phoenix for the winter, you lose that whole gap, which could be 4 to 6 months for some people, of that continuity of care. And it's how do you utilize telehealth and other things now to keep that connection, and you maintain that relationship as the main provider that whole year. And if they need to go see a specialist or something else while they're down there, that's great. But for regular ongoing visits, chronic care management, things like that, doing that through telehealth. So I think there's a new angle for a market share grab if providers look at that there also.
For all the attendees, if you need more clarity on any of the answers, feel free to throw that in the Q&A also, and not just the questions. But if you're looking for clarity, bring that out. I think all three of you can answer, but I'll start with David. Okay, we internally, we refer to FCCRA as FCRA here. So I'm just going to use VECRA here, and that's what I mean is FCCRA, okay? What challenging questions have you been asked regarding it, what you're doing with it, and how are you answering them to the staff and to the external?
There's been a lot of guidance on that, and in some cases, early on in particular, you provided some guidance, and then it's kind of like PPP. They updated the guidance, and it was completely different than what they had said before. The issue that we're seeing now, after almost a full year of this, isn't necessarily those individuals who are testing positive. It's those, I'll call them repeat offenders. It's the individual who, through some miracle, has always, every 2 weeks has a close contact. And so this person needs to go into quarantine, and FFCRA only applies so much, and let's assume in most cases that money's already been spent. There's no new money so far in 2021, and the question is, what do you do with that employee who this is his first or her fifth go round of needing to quarantine? At what point do you need to cut ties? Can you cut ties? And that's a question that really hasn't been answered very well. I think it just goes back because you think about it, if it's not the employee that needs to be quarantined, it's not his health condition. So you don't really have a ADA or FMLA issue. Even if it's a family member that has it, the ADA doesn't really protect the employee in the event a family member has something. So those kinds of folks are getting caught. And I think after a year of this, employers are starting to make some tough decisions about what do you do in those cases where the employee may not have any legal protection. But the question is, what kind of an impact does that have on morale? Where someone is in good faith trying to comply with the CDC guidance, and his coworkers all of a sudden see that this guy is getting terminated. It is the lesson then for the employee. I don't want to lose my job. I'm not going to tell my employer I've had a close contact, and I suspect that's what's going to happen.
So as far as risk, I think throughout the pandemic, we saw some facilities in the news or some headlines about facilities allowing asymptomatic staff to work, staff that have potentially been exposed but continue to be asymptomatic to work. What are the risks around that? I don't know that happened in every facility, but I believe it did happen. And to allude to what you just shared, Dave, if there's folks that don't share that they've had an exposure, talk about what those risks are out there for all involved.
Again, I think that the lodestar is you follow CDC guidance, and if you become aware of a close contact, you require a quarantine. And if you don't know, you don't know. Now, the way to get around that, I suppose, is to take the temperature, which is, as we all know, of somewhat limited significance. You can ask the questions, but you depend on the employee to answer honestly. So I think in terms of liability, there's only so much you can do. Obviously you can test. I know some employers require testing periodically. That's expensive. Not a lot of them do that. In certain fields, healthcare, you do it more often. So I'm not sure. There's always liability, but to the extent you have someone who's asymptomatic that comes to work and you're unaware and you've taken other reasonable precautions, I'd be okay defending that one.
And I would say from a provider standpoint, we have had a number of cases where we have brought employees who had close contact back on crisis staffing. And CDC outlines pretty specific guidelines. State of Wisconsin does as well, following their guidelines as to how we have to do that with serial testing, testing before every shift. Actually, I think it's every 72 hours you need to test. What we opted to do once we finally secured good in-house testing is we send the initial test to our state lab, which is a PCR test. Then we have a modified PCR test we do before every shift to assure that the people we are bringing back stay COVID-free. We've been fortunate. We've not had anyone who we've had on crisis staffing then test positive, but it's very possible it could happen. We implement that very judiciously. It's gotten some really interesting questions from staff. You know, why was I made to quarantine? And I'm a good example. I couldn't come back on crisis staffing because I'm not considered a critical healthcare worker, and I can do most of my work from home as well. But we've made some choices. You know, we may have 1 or 2 RNs out. That doesn't put us into a crisis where we think we need to implement critical staffing. But if you get up to 4 RNs, it may be a whole different story. So the communication, I think we dropped the ball a little internally as we were doing this to not do a better job of explaining what crisis staffing, how we make determinations as to when we bring someone back on crisis staffing. It's just that whole communication piece, but we've had to use it. We haven't been bitten by it, and it's worked very well for us to keep to the point where we are able to staff for our patients.
Talk about requirements of the employee. Can we require vaccinations as a question? How do you address that?
Yeah, the initial guidance is yes, with some significant exceptions. You've got the religious exception, which if someone has a sincerely held religious belief that they can't have a vaccination, you have to reasonably accommodate that. So does that mean that the person can work remotely instead of on site? Does that mean there are other enhanced safety gear that they can wear if they can't get vaccinated? So you've got the religious issue. You have the ADA issue. Does someone have a disability or medical condition which makes it inherently risky for them to get a vaccine? And again, you go through the same questions that you do whenever you have a disability issue and are asked to reasonably accommodate that. You know, can this person work remotely? Are there other things that they can do? And interestingly, the guidance says, okay, at some point, most of your work site is going to be vaccinated. So at some point, does it become a moot question where it's not as much of a risk if you have almost everybody vaccinated except these people who have some pre-existing medical conditions? So I think the more that people are vaccinated and the more that gets into the workplace, I think that becomes a consideration of what's a reasonable accommodation. So in a short nutshell, that's what's out there so far.
So I think we all endured conversations or personal ties to the financial hit that COVID, or the financial storm that COVID created for facilities in the year of 2020. We saw the volumes significantly decrease as facilities closed, people were asked to stay home, and then we saw the surge come. So what have you seen as far as creative ways for hospitals to compensate for some of those financial challenges from last year? And what would be some potential best practices?
I was kind of waiting for Ralph to jump in on this one.
You know,
he's thinking hard. I can see
I'm thinking on this one here because, you know, we've seen all kinds of different things. You know, I think the biggest part has been, you know, for a large portion of our providers, we've actually seen them recover a lot of their revenue, which is odd. Not what we expected. We actually saw them pick up some additional, as they reopened things, they saw some of that revenue coming back. Some will tell me that they've actually recovered back to whole, which was odd. Sometimes that's with and without the PPP and some of those other components. So what have we seen people do creatively? Obviously, we saw a lot of people doing some focused furloughs early on. And a lot of that was, you know, there were ways, depending on how you were looking at that versus some of the unemployment dollars and everything else, that you could still keep people whole. If they were in non-essential roles, that you could get by with less of them, or, you know, whatever during that time period. That was a big piece. We definitely did see some that were doing things in the area of trying to control costs through temporary pay cuts. And I think Dave, kind of hit a little bit of some of the potholes that you got to watch for on that side. Physician agreements have been a little bit more of a challenge because they're the contract pieces. However, I will have to say that I have been, as a whole, very impressed with the physician groups coming to the table and opening that up and having good conversations. It's not always that easy when you're working with your physician providers, but they've been, it seems like, a lot more open and understanding that there's a bigger piece here, especially for those entities that are using it about how they're trying to preserve the rest of the team too, in that need, because the providers see the fact that, they've got some of their staff and the people they work with every day that they don't want to see gone and hurt from that perspective. On the flip side, the other thing that I've seen people do to try to control costs has been becoming really creative in their compensation with the clinical staff, the nurses, the type of people that can go to some of these outsourced, like traveling nurses and traveling whatever pieces. In some markets, we've seen a huge uptick by those traveling entities to recruit people, basically move them out of your market, put them in some other market at a high cost. And then of course, they're the same ones that are coming in with solutions for you on the other side to sell you back people. And so I've had some facilities that have been really looking at how do I augment my compensation temporarily so that the individual doesn't have that incentive to go take off and run with a temporary entity, which would be temporary for them there too, because someday things are going to come back to normal. So there's been a lot of things like that, a lot of temporary push out of projects. And when I say projects, that could be saving cash flow for capital. Yeah, we really want to get these things, but right now that might just be something we got to push out 6 months. It's not off the table, but it's not on the table. My type of work, people like myself, maybe, Dave and things like that, there were, projects that they have us looking at doing, saying, you know what, that's just going to have to go on the burner. It's something we know we need to deal with, it's, compliance reviews or, revenue cycle reviews and things like that, yeah, I know I got to do it. I'm just not going to do it now. So it's kind of trying to push that out into the future. We're starting to see that open up again now, though. It seems like there's been a lot of things that have been pushed probably as far as they can. So some of those things that weren't urgent are now becoming urgent. And so we're seeing some openings there. The continuous viewing and looking for available funds too, making sure that you're getting all of your, your PPP and PRF and documenting those strategies too. I know some big systems have given all that money back, but the small facilities I'm dealing with, they can't necessarily, there's not a way for them to give that back. So they got to make sure that they're securing that. So every facility is a little different strategy. Oh, the other piece that I'm seeing, and this is something to think about, you've made staff changes and operational changes due to COVID. At some point, the PHE will go away. And some providers are like, yeah, we'll just move everything back to the way it was. And what I'm seeing more of my creative facilities doing is standing back and saying, what changes are sustainable? If I made a change in staffing, did that crisis occur that I thought might occur? Or did we figure out a way to do more with less? And so not just automatically reverting back to, oh, we're healthy again, we're going to hire back all these staff, or we're going to put our processes all back to the way they were. Making sure we learn from what we can learn from. It's a heck of a way to have to learn. But if we can learn some things, make sure that lesson was not lost.
It kind of speaks to Mike's normal for now. What worked well that you want to keep doing?
Yeah.
I would just interject, we're not one of those fortunate ones that saw everything come back like we've seen others. An example is our emergency department still runs about 10% lower visits than we had last year. So you would think that our emergency staffing company would drop our rates a little bit, but I haven't seen that happen yet. We use Wapiti for those of you wondering. But what has happened is we're not seeing the urgent care type patients that don't need to be in the ER. It seems we are seeing actually a more acute patient in the ER. So the drop in volume, they feel they're busier than they were. So there goes my rate cut, I guess. We worked against it. But we have some departments that came back right away. Surgery has been an interesting one for us, as we rely on a lot of outside physicians to come in and do specialty clinics and that. We have one physician who still hasn't come back because he's COVID phobic and is doing very little. We've had our two biggest things that we do back in our surgery in our clinical area back there is cataract surgeries and colonoscopies and that. And after not doing any of those for a month or two, they've been scheduling extra days. So they're getting caught up. Most of our departments are back. Our inpatient has stayed pretty consistent. We made the decision not to accept as many swing beds in the past to keep beds open for the anticipated surge. And we didn't see, I think we run an average daily census of 6 here. We're a very small hospital. At one point, we saw 4 COVID patients at one time. We had actually converted permanently a negative pressure room and 2 others that we've converted as well. But a department like our rehab services, PT, OT, they're still down. And we rely a lot on referrals that we're getting from the larger tertiary facilities that are doing major orthopedic type surgeries. And people are still on waiting lists for those, it seems. So that's the one area we've really felt it more than anything is in our rehab department.
How about on the inpatient side? Did you have to make any big adjustments knowing that COVID's coming in? Do I want to keep these patients last April? And then what's your take now?
We were that's one of the reasons our swing beds are in the same population. That's one of the reasons we limited swing beds we took, because we knew we couldn't move those to nursing homes should we get this influx of COVID patients. So we were very particular in those patients that we did accept. We have learned, and I think anyone who's listening in on this, who works in a rural hospital, we know that the larger tertiary centers aren't always 100%. I hate to use the word honest, maybe transparent's a better word, when they're trying to send you a swing bed or something. And we found that as they got busier, some of the things that a couple of them tried to send to us were ridiculous as swing beds. They were patients we probably wouldn't accept as an inpatient. They weren't stable. So we had to be very careful even in the referrals that we get, so that we didn't end up taking up our negative pressure rooms with patients that we probably shouldn't even have in our facility.
So I like your comment, Ralph, about the changes that have been implemented and how many of those are sustainable, as the situation has caused all of us to think outside the box and do things that we never thought were possible. As we look ahead, I think it's important to understand, as far as the telemed piece, how much of that is sustainable and how much of the expectation of that from future employees will stick, as well as other workforce changes that need to happen to meet the changes or the ever-changing landscape.
Was that a question or?
Yeah, a question as far as the sustainability of it going forward. Mm-hmm. What do you view that to be, probably for both Mike and Ralph?
Yeah, I think there's a couple of pieces. The work at home component of that, I do think that we are going to continue to see people focus on what they can do from work for home. There are a couple things that you've probably got to caveat that around, is that, we know that there are some things that that people lose if you don't have some interaction and continuity. One of those things I think is growth. Because, most of us grew in our organizations by being around people and leaders and being tasked and given opportunities because we were close to these individuals. When you work in the remote setting, one of the concerns I think that we're going to have to look at long-term is, how are we developing the leaders that will replace the leaders that are in those leadership roles today? So if you're thinking business office, revenue cycle, HIM, any other administrative functions that are typically the ones that are obviously not patient related or patient care related and working off site, how are you going to develop that? I mean, yeah, you can get by with that for 9 months to a year, but what happens when your leadership leaves, retires, whatever? Where's that new leadership piece coming from? So I have some concern about sustainability there. And I think, you know, there's gonna be people that wanna work remote and you may allow them to do that, but it might be having some real conversations about if you have a career path, that might limit your career path because you don't get the experiences. And if you don't get the experiences, how do you get to that next spot?
I'll jump in and talk about remote work a little bit. Even before COVID hit, I think employment lawyers saw an uptick in requests to work remotely, and it was usually based on some ADA thing, some medical condition where someone wanted to work remotely. And I think there's been a concern since we've had all kinds of folks working remotely and continue to work remotely. As an employer, are they going to be able to reel them back into the workplace? And I think the EEOC so far has said, yeah, just because they're working remotely now and it's been successful doesn't mean you need to keep them there. You have the right to bring them back in. So two things. It's always going to be an ADA issue on remote work. If someone has a medical condition that their doctor says, yeah, this person needs to work remotely, that's always going to be an analysis that you have to do. And keep in mind, it's not an all or nothing thing sometimes. To Ralph's point, maybe they work remotely a couple of days a week and come back so that they get the benefit of the workplace and the interaction. The other thing I think it's important to think about going forward is the old job description. From an employment lawyer's perspective, I want my client to tell me that working at the regular work site is an essential part of their job. It's just not convenient, but it's essential. And I think you need to build that into your job descriptions, even without COVID. I think it's important for HR to go through these positions, position by position, and say, yeah, this person's job, it's essential that they work from the workplace. At least then you've got an argument when someone wants to work remotely that, no, you can't do your job remotely. It has to be here. So I think that the one thing that's never going back the way it was is the expectation that employees think that they can work remotely and do their job. Law firms, younger lawyers would prefer to work remotely than they do to see us old guys walking around the hall. But again, to Ralph's point, I don't think young lawyers grow as much and learn as much when they're not here having daily interactions with the rest of us. And I think that's true whether it's accounting or a lot of other fields. I think that they do lose something in the process. It may be convenient to be at home, but I agree. I don't think you grow as quickly or at all as you would if you were at the general work site.
Addressing that from an employer standpoint, I'd like to address it from two different standpoints. We have one person working remotely now out of our 150 some employees, and she has a medical condition. We months ago brought everyone back to work because we think we can do it safely, and we think there's a real benefit to having them here. I lost a very good IT person because she could work from home for somebody else. You would think IT worked, but the role of that IT was working with our nursing staff and different things as our go-between with Epic and that, and felt it's so important to have them here at least part-time and allow them to work from home sometimes. So I kind of laugh a little when I hear about the accounting firms or the attorney firms that everyone's still working from home, because we've been back socially distancing, masking, and doing things appropriately for months. I want to turn it to the patient standpoint, though, because quite honestly, in my 35 years in healthcare, the way medicine is delivered, healthcare is delivered, hasn't changed a lot, especially from the clinic standpoint. I mean, we've tried the patient homes, chronic disease management, all those different things. But the way we deliver care is in a clinic setting is that patient comes into an appointment, sees the CMA, sees the doctor, discharged. The younger generation is no longer going to allow that. And a prime example is my daughter. She has her next neurology appointment set up, and she's 4 hours away from the neurology clinic in Minneapolis at school. for me, I'm used to going to the doctor. That's the way it is. But we are hearing more and more that the younger generation is, I don't need to take an hour out of my day for a 15-minute appointment and travel. I just want to do it. And I think that's going to drive telehealth as much as anything. It's going to be the consumer demand of the generation that is much more adept to technology than people like me.
So Mike, with that, it kind of begs another question I've had with providers. So we do the telehealth, and my mom, she learned to love telehealth during this whole thing. Her big beef now is that when I need to get my lab test, I still have to come in your hospital. Yep. So what are we doing? You know, and so you think about these drive-by, you know, collection things. I think that those are going to be a thing of the future regardless. Because if I don't have to come in and all I got to do is swing into basically a garage, almost like a car wash. You come in, they open one door, you come in, they collect, you go out the other side, and I don't have to come inside. The convenience factor is going to be something I think they're going to demand.
I agree, and it's going to be hard in some areas to do that. But how far are we to having all that lab done like a diabetic? My mom's diabetic, how she can check her blood sugar and have it sent off to her provider. How far are we going to be away from that for other blood tests and other work as well? I don't think we're that far off from there. You can get a medical quality EKG now on an iPhone. So I think that technology is going to drive that even more so. But I agree. I don't know how we're going to cope with that, because I can hear exactly what your mom's saying. I can do everything. Why can't they figure out a way to check my blood without me having to go wait at the clinic?
Yep.
Thank you very much, guys. Joe, I think we're ready for our next conversation. We could talk about care for the elderly and how they're going to adjust and how some of us are going to adjust. Everyone listening, thank you for taking time out of your day to ask questions, clarify the questions, listen to the results. I want to thank Dave and Ralph and Mike for giving us some of the guidance and some of the, I guess, the experience and knowledge that they have. On behalf of Jen and I, if you have follow-up questions, please send those to Troy or Jen. You can look us up on our website at Wapiti, but we're happy to coordinate those questions through Mike as another CEO, Mike with Ralph with Eide Bailly, who you will all know, Dave with Woods Fuller, who has offices in Iowa. So again, thank you, everyone.
Thank you.
Yes. Thanks all the panelists, and thank you, Troy and Jen, for an awesome session. So I will be sending out the recording to all our attendees probably yet today. So I want to thank you all for joining us live, and thank you all who are viewing this recording. And at that, I'll conclude this session. So everyone have a great day.